All right. Happy Monday, everybody. It's almost April 1st, almost April Fool's Day. Just a couple more days left to this month. Only about a few more classes and we'll do our final. And I'll talk to you about our final here in a couple days. So today we're going to do chapter 21, vasopressors. So everybody knows that's going to squeeze our veins. Inotrope, that's going to make the squeeze of our heart greater. And then antiarrhythmic agents, so things that are not going to let my heart go flippy flop. Okay. All right. So let's talk about what we have to talk about when we talk about these drugs. We have to talk about the cardiovascular system. And yes, you're going to see strips come back into play here. EKG strips. I know that's everybody's favorite. Ooh. Okay. So let's talk about blood pressure, because blood pressure is one thing that makes the blood go around, right? So what affects our blood pressure? So you have a high number and a low number, right? A number on top, a number on bottom. So that number on top is our systolic blood pressure, okay? And we want it to be a little bit higher. The number on the bottom is that diastolic pressure, and of course we want it to be nice and low. But you'll hear a lot of times they'll just talk about the MAP, or the mean arterial pressure, not mean airway pressure. So be careful what they're asking for. Okay, so the MAP, that mean arterial pressure, that's what's going to drive the blood into the tissues during that cardiac cycle. Okay, this mean arterial pressure. All right, and how can we figure out what the MAP is? Well, there's a couple ways we can do it. One, you're not going to be able to get because you've got to have a whole lot of calculations, and if they don't have hemodynamic monitoring going on, you're not going to get it. But an easy way is to take the blood pressure you're given. Okay, so if I have a blood pressure of 120 over 80, I'm going to take 2 times the diastolic pressure, which is 80. Okay, and so 80 times 2, right? So 80 times 2 is 160, right? Okay, so then you're going to add that to your systolic blood pressure, which we said our systolic blood pressure was 120, and we're going to divide that whole thing by 3, okay, and that will give you your mean arterial pressure. You could do it where you got the cardiac output, okay, CO is cardiac output, times your SVR, your systemic vascular resistance. All right, so then you have to figure out cardiac output. That's not feasible for most patients, all right? So if they ask you on any exam, they're going to give you the blood pressure, and that's how you're going to find your mean arterial pressure, okay? We love for our mean arterial pressure to stay around 90. We never want it to go below 60, okay? Yeah, I know everybody remembers what cardiac output is, right? It's the amount of blood that leaves the heart with each contraction. So each time that left ventricle squeezes and that blood leaves, that's our cardiac output. How do we get that? Heart rate times stroke volume, okay? So I'd have to give you stroke volume, okay? And if I gave you heart rate, you could tell me what the cardiac output is, all right? So if I wanted to figure out what MAP was, I could take the heart rate times the stroke volume times the systemic vascular resistance, but that's not going to be the common way. You're just going to do it the 2 times the diastolic plus the systolic divided by 3, okay? All right. So the ways we can get, if I wanted to get cardiac output, right? A pulmonary artery catheter is something that we would use, right? That's how I'm going to get my hemodynamic monitoring, okay? We're going to get pulmonary capillary wedge pressure, central venous pressure, okay? All of those things. So I can now use this pulmonary artery catheter to tell me how is my vasopressor or my vasoactive therapy working? Am I pressing? Am I opening? What am I doing? And then we can figure out where the hypotension is coming, because that's really what we're talking about in this chapter, is someone who's got hypotension and that mean is low, and we're going to have to give drugs in order to get that blood pressure back up. Because remember, we have to have a MAP that's going to allow to drive the blood into the tissues, okay? Remember this for your exam, and goes for board exam. Okay, anytime we have a hypotensive crisis, pressors are not going to be the first thing we give. Inotropes are not going to be the first thing we give. A fluid bolus. So on your simulations, when you've got a patient who's hypovolemic, the first thing you're going to give is a fluid challenge, or they call it a fluid challenge, a fluid bolus. We want to see if just giving them some fluid will bring up that blood pressure. Okay. All right, so let's talk about shock, because that's really what we're talking about here, is usually a hypovolemic shock, a septic shock, one of those types of shocks where we're going to tank the blood pressure. Okay, so what are we going to give for shock? So we're going to give a couple different classes of drugs. Catecholamines, and catecholamines kind of act like epinephrine, in which they squeeze the vasculature in order to increase blood pressure. Okay, and then we'll use inotropic agents, and the inotropic agents are going to make your heart, especially the left heart, squeeze harder to push out more blood. If I push out more blood, I'm increasing what? Yep, my cardiac output. And if I increase my cardiac output, I'm going to increase that blood flow around the body. Okay. So when we talk about catecholamines, we're talking about norepinephrine, isoprostol, dopamine, phenylephrine, which is neocephalin, vasopressin, which you'll hear a lot in codes. You'll hear a lot of them call out for vasopressin. And then our inotropic agents, dobutamine, phosphodiesterase inhibitors, and cardiac glycosides. Okay, so just remember, the catecholamines are going to squeeze the vasculature, and the inotropic agents are going to squeeze the heart. They're going to make the heart squeeze harder. Okay, so norepinephrine, and I know y'all all hear it, Levophed. That's all Levophed is norepinephrine. And then we can give epinephrine, which is another name for adrenaline, right? But we typically, if we're having a code, what do we give them? Epinephrine. If I've got Levophed, that's something I'm going to hang because we're having trouble keeping their pressure up. So you'll hear them say we've hung Levo. Okay. We make our own epinephrine. So when my blood pressure goes lower, your body's going to try to compensate by spitting out some epinephrine or adrenaline, and that's secreted through your medulla, adrenal medulla. So basically the little triangles on top of your kidneys, right? The adrenal glands, we're going to get a signal from the brain that's going to tell us to secrete some epinephrine. And when we do that, I'm going to get vasoconstriction and I'm going to get some tachycardia. Okay. All right. Isoprel. That's not something we make. Okay. That's something we give, and it's a synthetic catecholamine. So if I've got bradycardia and or torsades, so if I've got a patient who has gone in and out of torsades and we brought them back, let's say that we coded the patient and you noticed they were in VTAC, but the VTAC was torsades. And I know everybody here remembers what torsades is, right? Twisting of the points, okay? So we will give them, we bring them back. We may give them isoprel to try to keep them from going back into torsades. Does anybody remember the other med we would give for torsades during the code? Yes, magnesium. I knew you guys knew it. All right. It's a beta receptor agonist. So remember, we got beta 1 and beta 2. Beta 1's on the heart. Beta 2 is on the lungs. So it's got beta 1 effects that are going to be inotropic, going to make the squeeze harder, and chronotropic, meaning it's going to speed my heart up. Okay. And then beta 2, it's actually going to be a smooth muscle relaxer. So my bronchi are going to relax, my skeletal muscle are going to relax, my vasculature will relax. Okay. We're very careful on this because of the heart rate. So if I've had somebody who's got some unstable bradycardia and I give them isoprel and I push their heart rate up too high, we can have some issues. Okay. Dopamine, you will see that a lot. We make that inside ourselves as well. Okay. So basically what happens is we have dopamine in our body. We will bring other drugs into it, and it will make norepinephrine. But sometimes I just let dopamine go inside my body, okay? But it is the precursor and what is needed to make norepinephrine inside our body, okay? We call it inotropin or dopamine, but it is dopamine, all right? It's a vasopressor. All right, I'm not going to ask you to know the doses, but it is a vasopressor. It's going to stimulate, again, those beta receptors. So it's going to have chronotropic and inotropic effects. Please make sure you know what those are, chronotropic and inotropic. All right, so if I've had a heart attack or if I've got very unstable heart and I use dopamine, I'm going to have to watch out because it is going to increase my afterload. And if I increase afterload, I'm going to increase my oxygen demand and the oxygen demand of my heart, okay? So I have to be very careful when I give dopamine because I can give you an SVT, supraventricular tachycardia. I can give you some PVCs. The patient can talk about palpitations. And because my heart has gone up, my heart rate's gone up so much, I can get some decreased perfusion, okay? All right, so this phenylephrine, which is neosynephrine, okay, it's nothing but an alpha agonist. So it's only going to work on the heart and that's it. It's going to vasoconstrict the vascular beds, okay? It's basically going to increase your total peripheral resistance. And if we remember, that's how we kind of figure out what blood pressure is it's that total peripheral resistance, that systolic blood pressure. What is the pressure it takes to move blood around? Diastolic is on relaxation, okay? The problem here with neosynephrine, we have to be kind of careful, is that it can cause aortic vasoconstriction. And when we do that, we can get some bradycardia, okay? But in a emergent situation, we're not worried about that too much, right? It doesn't do anything to the respiratory side, right? Because it's an alpha agonist and not a beta agonist. All right, the one you see a lot besides the levofed is vasopressin or pitressin. You just hear them call it vasopressin, okay? It's going to have us retain water. It's also going to vasoconstrict. It's an anti-diuretic hormone. So if I'm anti-diuretic, means I'm not going to pee, okay? We typically don't use it as an agent just alone and say, I'm going to give you vasopressin. This is where we see vasopressin used is a lot in our code situations. When I've lost my blood pressure, I need to hold everything in. That's where you're going to see us use vasopressin. If I've got a really critical patient in the ICU, we're giving them levofed, we're kind of maxed out on the levofed, then we'll add vasopressin on because it's going to decrease some blood flow into your spleen, which can cause a problem immunologically because, everything runs through our spleen. It's made to clean stuff out. So this is not our first choice to give as a lone agent, but in emergent situations when they're coding, this is great. As a backup to levofed, it's another good med, okay? All right, so let's talk about inotropic agents. So these are gonna be ones that are gonna make our heart squeeze harder, more effectively, okay? So dobutamine, and you'll hear it just usually dobutamine. Basically, my patient's in heart failure, okay, because their heart's not compressing, not squeezing like it should. So we're going to give them some dobutamine. This is a short term. This is not a long-term treatment. This is short term until we can get them stabilized and then on a more long-term med, okay? This is synthetic. We don't make this in our body, but it kind of mimics dopamine, all right? So that's why it doesn't stimulate those dopamine receptors, but it's dopamine-like, okay? So it's going to be positive on inotropic, meaning it's going to make me squeeze harder, and chronotropic, which means I'm going to speed up my heart a little bit. And then the thing here, it's going to make me vasodilate a little bit. So if I have a low blood pressure, this is not something we would give, okay? Because now I'm going to vasodilate, all right? What we see is this, you're going to get some tachycardias. I can get hypotension. And because I'm increasing my heart rate, I can increase that myocardial oxygen demand for my heart. So we have to be very careful with dobutamine. This is a very short-term issue, short-term med for my heart failure patients. Okay. Two other ones that fall under the phosphodiesterase inhibitors class is Inocor and Primacor. You're probably not going to see those all that much. They're inotropic vasodilators. So again, they're going to make me squeeze, but they're also going to vasodilate. Okay. So these are just know the class. You're not going to see these too often. Okay. So we'll have to work with patients who have renal impairment and if they have severe cardiac issues. All right. All right, cardiac glycosides. This one you'll see, digoxin. You'll see that a lot. So if you hear linoxin, same thing, digoxin. These are the patients, this is what I'm going to give my chronic heart failure patients. They're going to be home on digoxin. We might have started them on dobutamine just to get them for that short-term heart failure issue they're having. And then we're going to switch them over to digoxin in the hospital so we can see how they react to the digoxin, okay? It's inotropic. It's going to make that heart squeeze more efficiently. Okay. It inhibits our vagus nerve. So what does that tell me? Our vagus nerve do. Okay. We don't see hypotension, which is a good thing. But here's my problem: a very narrow therapeutic index, which means I can get toxic very easily. My patients will come in with nausea, vomiting. They don't want to eat, pain. Okay. And this is where I have to watch out about using digoxin if my patients have any kind of kidney issues, because I'm going to eliminate digoxin. I'm going to pee it out. So let's say we give digoxin and my patient's a 3-day dialysis patient, but they miss dialysis. Guess what? They're not going to be able to eliminate their digoxin and may get toxic. Okay, those are the two classes and a couple of the meds that I wanted you to know. This is just a quick overview. I know all of you know this, and I know you know this. So let's just talk about how the electricity runs through the heart. We all know that we go from the SA node to the AV node to the bundle of His, through the bundle branches, down the Purkinje fibers, right? That's how my electricity flows through my heart. And that my SA node is the pacemaker, right? And what is my typical heart rate? 60 to 100. So my SA node will fire somewhere between 60 and 100. If my SA node fails to fire, my AV node is its backup, okay? And it will fire somewhere between at a rate of 40 to 60. Not how I want to do it, but I will. A rate of 40 eventually is not going to make me very happy. So my SA node is going to send out the signal. My atria are going to contract. Okay. Then that message keeps going to the AV node, and that AV node is going to link my atria to my ventricles. So if something happens to my AV node, we're in trouble, because now I don't have a link between my atria and my ventricles, okay? So that AV node now is going to send the message through the bundle of His, the bundle branches, and the Purkinje fibers, okay? And it all happens in an action potential. Oh my God, y'all remember that? I saw everybody's face just fall when I said action potential. But what is the SA node? When the atria contract, what does it make? It makes the P wave, right? When the ventricles contract, what do they make? The QRS. And when the ventricles relax, we get the T wave. We don't see the atria relaxation, right? Because it's obscured by the QRS complex, all right? Okay, so let's talk about this action potential. Remember, we're gonna have 4 phases, really 5 phases, because we have a phase 0. So that action potential, phase 0 is an initial rapid depolarization of my tissues, okay? So we're gonna get sodium rushing through these fast sodium channels. So we're gonna get rapid depolarization. And then phase 1, the sodium channels are inactivated, and we're gonna get
because they're inactivated, now potassium and chloride are going to come in, and we're going to start to get repolarization, okay? Phase 2 is that plateau where calcium and potassium are going to be balanced. So we got a balance. We've got this plateau, nothing's really happening. And then in phase 3, those calcium channels are going to close, but I still bring in potassium, okay? That's going to let me continue that repolarization. And then in phase 4, it comes all the way down to the bottom, and I get into the resting state. And that resting membrane potential means now I can go and have another action potential start, and we can go into phase 0, and I can start this heartbeat all over again, okay? So if we get distracted in any here, or anything gets discombobulated in any of those phases, we can have some abnormal beats, okay? All right, and I know you guys all know what the heart looks like, okay? But here's my SA node up here in the top of my right atrium, okay? Your AV node, again, is down here about 3/4 of the way down in your right atrium. And then we're gonna start out and have the bundle branches, and you're gonna have your bundle of His, okay? And then your left and right bundle branches that are gonna go into your Purkinje fibers, which are going to go all down into your ventricles, okay? All right. So what happens if I have some of these cardiac cells that get agitated outside of this normal conduction system? Because that's what abnormal beats are, is I've got a cell outside of this SAAV bundle branch, Purkinje. There are cells outside of that are being agitated. Okay, so when we get that, especially in the atria, we get atrial fibrillation. Okay, so what we can do, and what you'll see, is we'll give patients medication. Maybe the medication doesn't work, or we try something different. We try what we call an ablation. We take the patient to the EP lab, the electrophysiology lab, and we put in a catheter, and we identify the cell that is being irritable. And we basically take this radio frequency and we burn it, and we try to burn it out. So typically what happens is that will work for about a year, sometimes 2 years, and then another cell outside the conduction system can then start to come back in and say, hey, I'm taking over where you killed this cell, now I'm gonna take over, right? So you can have usually 2 ablations, and then they won't do any more. And then it's just going to be medication, okay? So it's successful, like they say here, 30 to 90% of the time over about a year. Some people a little more, some people a little less, but they'll really monitor them to make sure that they're not having more irritable circuits, irritable cells outside the normal conduction system, okay? Let's say that it's not working, medicine's not working, but at the same time, I'm now having, so let's go back to that ablation. If medication, we're having to go medication, and we're having a lot of trouble with that SA node because of all these things that are firing outside, that's where we're going to put in a pacemaker. And this patient is just going to get a pacemaker to now be the SA node. Okay, that's what's going to happen. And it fires off, and it then sends the message down to the AV node, and we keep going from there. Sometimes we'll have these patients who now, they've been in SVT, they've gone into ventricular tachycardia, they've got really bad bradycardia. So what can we do for them? So we may actually implant what we call an ICD, or an implantable cardioverter defibrillator. So basically what it is it's a little bit bigger than a pacemaker. So over in the right side of your chest, it'll be a little bit bigger in that upper right pec, okay? And they'll put it in, and basically it's almost like a continuous EKG monitor. It's monitoring what rhythm you're in, and if it thinks that you are in VTAC or a bradycardia that's going to put you down, it will give you a shock, okay? Basically, they'll do this if we have patients who go into VFib or VTAC, sustained VTAC, if they're having fainting with VTAC or VFib and they don't tolerate the drugs we give them, they have MIs, left ventricular dysfunction, things like that. Drug therapy is not enough for them. So we're going to implant, and you could make this a kind of combo pacemaker / defibrillator. They'll have them both, where this patient will also, it's all in one. It's going to pace the patient, but also defibrillate them if something outside of the normal conduction system puts them in VTAC or VFib. Okay. All right. So let's talk about now the next, we've just talked about the conduction system and how we get, PVCs, a run of PVCs, which is VTAC, all of that. So let's talk about what we call antiarrhythmics. We're going to have several classes of these, all right? And y'all are going to hate me, but don't hate me too much. You love me anyway. These are going to make sure that we stay in our normal conduction system and we try not to let any beats come outside of that. It's going to help with those your arrhythmias. And so it's an antiarrhythmic. All right. And these classes are going to be basically how they work. Okay. So the first class we have is called class 1A, and it's going to block those fast acting sodium channels in the atria. Okay. So it's going to block those so I can't have as much sodium going through. So if I can't have as much sodium going through, that's really going to slow down my heart rate, right? It's going to slow everything down, okay? And it's going to block the repolarization of allowing that potassium to come back in. Quinidine is one of those. It's used with AFib, a flutter, okay? We're going to put a rate controlling drug first. I'm not going to use this if I have asthma. So if I give you something where a patient has asthma, you're not going to do this. Can you overdose on quinidine? Absolutely. It'll give you respiratory depression, okay, vomiting, diarrhea, seizures, hypotension, syncope, and some EKG changes. But the biggest thing is for us is respiratory depression. So just remember, it's going to block sodium, the fast sodium channels, and it's going to block how much potassium can come back, okay? So that's that action potential right there, okay? So it's phase 0, 1, 2, 3, 4. So remember that, okay? The other class 1A is called procainamide, okay? We don't see it used as much anymore, but we use it for VTAC and torsades. The thing we don't like about procainamide is it gives it can give the patients a lupus-like effect, where their white blood cells kind of attack their own body. So it can give us some leukopenia and things like that. But it is a good job, and it will do the same thing. It's going to block those fast-acting sodium channels and slow down the potassium rush in. Okay? So remember, VTAC is over here. VTAC, right here, VTAC. Okay? Here is fibrillation. Okay, there's flutter, sawtooth, looks like the saw, and then flutter. Okay, so just make sure you brush up on those, because I bet I have some strips on the next test. Okay, all right. So another class 1A is Norpace. All right, and that'll be for life-threatening VTAC and paroxysmal supraventricular tachycardia. Most of these drugs we're going to start when they're in the hospital, because we want to see how the patient reacts. Okay, because Norpace can have a negative inotropic property. Okay, so we said positive inotropic meant your heart went faster. So what do you think negative would be? Negative means it's going to slow your heart down. Okay, and it can have some anticholinergic side effects. So if we remember what anticholinergic drugs do, they're going to dry you out, right? So our Atrovent, all those drugs, they actually dry you out, okay? So be aware of that, all right? So be aware of that, and we have to look at the potassium as well, okay? Class 1B, so this is the next one, okay? Class 1A has a tendency to give you a few more arrhythmias, okay? They can be pro-arrhythmic. Class 1B does less of that. And the Class 1B drug that you probably are all going to be familiar with is lidocaine, okay? We're going to use that to treat all our ventricular arrhythmias, and I know you know that. It used to be the first-line drug when we were in codes, and we've taken lidocaine out, right? But we'll give this a lot for cardiac surgeries or after a patient's had an MI, okay? We can IV bolus and then give an infusion. It's going to be metabolized through my liver, so we have to be very careful that our liver is working, because if the liver is not working, it's going to build up and your patient's going to have a seizure, okay? So that's what we have to worry about, all right? Another Class 1B is called mexiletine. Okay, we're going to give it as a pill. And again, ventricular arrhythmias. It makes you sleepy. That's why a lot of people don't like it. That anesthetic property is going to make you sleepy. Okay, so it can, if you were to take too much of it, cause coma and respiratory arrest. This is not one we'll give a lot of them, this one especially, a lot of GI disturbances, tremors. Patients don't like it because they'll have difficulty walking, okay? All right, another Class 1B is tocanide, and then again, that's basically the oral of lidocaine. So if I'm gonna put the patient, we've given them lidocaine and I wanna send them home, I don't send you home on lidocaine because I can't. There's not an oral lidocaine, but I can give you this one, okay? So again, ventricular arrhythmias, myotonic dystrophy, trigeminal neuralgia. So myotonic dystrophy, so like muscular dystrophy, this is myotonic, meaning your muscles are going to be very stiff. You're going to be stuck in almost a tonic state. And trigeminal neuralgia is the trigeminal nerve that runs across your face all the way down, and it can have, it causes your face to be and your neck to be in terrible pain all the way down. So it's kind of meant to relax that. It does have a black box warning, which means we have to be very careful if we do use it, because it will interfere with lots of different drugs, okay? Because it can cause pulmonary edema, fibrosing of the alveoli, that's not good, pneumonitis, respiratory arrest, and different blood issues, okay? So this is not one they're going to give just willy-nilly, okay? All right, Class 1C. We don't give those very often at all, because when we give them, you're more likely to have other arrhythmias than the one we're treating you for, okay? But we can use Class 1C for supraventricular or ventricular arrhythmias. Everybody knows that supraventricular means this ventricular arrhythmia is happening above the ventricles, right? Supra, above. Okay. So the first Class 1C is Tambicor, all right? So we'll give it for AFib, aflutter, paroxysmal SVT means, so paroxysmal just means it happens all of a sudden and then goes away, okay? So we'll have this run of SVT and then it'll stop, and it'll start and it'll stop, okay? And then we have sustained VT. It has a very long half-life, okay? Which means it takes a long time for it to just get down to its half-life, okay? The problem here is that when we take it, we see a high mortality rate and some non-fatal cardiac arrest. So that's why this one's not given just willy-nilly either, okay? So the way it's eliminated is through your urine, through your renal system, but it's all dependent on your pH. If you have a very acidic pH, it's going to increase the clearance. If you have a more alkaline, it's going to decrease the clearance, okay? So this pill in the pocket, don't worry, I'm not going to worry about that. That basically is, you got a pill in the pocket. If you're feeling something, pop it in and see if it helps. So you would keep your Tambicor in your pocket. If you start feeling some symptoms, you pop the pill, okay? All right, Rithmol is going to be used for PSVT, okay? And basically after we've cardioverted you, so we've gotten you out of SVT or VT and we've cardioverted you and gotten you back to normal sinus rhythm, we're going to give you this drug. Typically, where we see this used most is for our AFib patients, and it's one of the first ones we give. Okay, here's the deal. It is a non-selective beta blocker, so not only does it do those other things that it will do, but it will sit in the beta receptors, which means if I've got a patient who's a COPD patient or an asthma patient, now I've decreased my number of beta receptors, my beta 2 receptors for my drugs. Okay, so we'll talk about that when we talk about beta blockers. Okay, so those were class 1. Class 2, the first drug in class 2 are the beta blockers. Okay, so what do we use beta blockers for? We use their first line for hypertension, and we use them a lot post-MI, because what they're going to do is really take down your heart rate. And if I take down my heart rate, I'm taking down the O2 consumption of my heart, and that's what we want. And in hypertension, it's basically going to help open things up, decrease total peripheral resistance. So now it makes it much easier for blood to flow. Okay, here's the thing with beta blockers. They all end in LOL. Okay, I'm telling you, if you see an LOL, propanolol, metoprolol, atenolol, nadolol, esmolol, those are all beta blockers. Okay, you'll see metoprolol used a lot. It's what we use for chronic heart failure. Propanolol is used a lot for hypertension. It's also used for migraines. You'll see metoprolol used for migraines. Okay, those are the top 2. Atenolol, we don't see used as much. Esmolol, we don't see used as much. All right, again, these are going to beta block. They're going to block your beta blocker, your beta receptors, all of them. They're not specific. They'll block beta 1 and beta 2. So you need to be very careful. If I've got, again, a COPD patient or an asthma patient, and I go to give a beta agonist, I don't have enough beta receptors to get good results from my drugs that I'm going to give. Okay. All right. So that was the only class 2 drug. Yay. Class 3. The drug that you're all seeing now that's taking the place of lidocaine is amiodarone, right? We use it for ventricular and supraventricular arrhythmias. So if I have a patient who is in who's got VTAC, we will give them amiodarone. Okay, so we get them back, or they're in a sustained VTAC, or I've got a patient whose heart rate is just off the chain in the 150s, 160s, 170s, 200s. We're going to give them amiodarone. It's going to slow it down. Okay, so it can give you some pulmonary issues, but when your heart rate's that high, or when a code situation, it doesn't matter. We will treat that later. Okay. We have to look at what drugs they're on, because it can have a lot of drug-to-drug interactions. So we have to be very careful with what we do with amiodarone. Okay. All right, we're not going to do that. The other class 3 is Multac. Okay, it kind of acts like amiodarone. Okay, but it's going to be a little less toxic to the thyroid gland. Okay. And we use this more on the outpatient basis. If they got amiodarone in the hospital, we typically will give this when they go home. If they're having persistent AFib, aflutter, or they're in a normal sinus rhythm, they're getting ready for cardioversion, we'll give them this. Okay, this is only given oral. Okay. Amiodarone is more effective for chronic AFib, but if this is a patient who's just going on, sometimes this works a little better for some patients. Okay. All right. A third one is Ticosine, again, another oral formulation. And basically, we've cardioverted this patient. And so we'll give this after cardioversion to try to keep them in normal sinus rhythm. Okay. It can give us some ventricular arrhythmias. We see this among females and those who don't have great renal function. That tells me it's probably eliminated renally, and it's got to build up. Okay, so again, this is one you have to give in the hospital before we can let them take it at home. And it's a very special combination. So not very many pharmacies actually make this drug. Okay, it has to be a tip, what they call a TIPS pharmacy. Okay. All right, Sodalol, and I bet y'all have heard of Sodalol. Okay, it is oral, and I've seen it on a lot of y'all's soap notes. Y'all have put it in there that they're on Sodalol. Okay, it's going to prolong my action potential. If I prolong my action potential and that relative refractory period, what's going to happen? It's going to slow everything down, right? So we see it for ventricular and supraventricular arrhythmias. It's going to slow stuff down. Again, we have to be in the hospital. We have to have 3 days in the hospital to monitor the patient so that we make sure that they're okay with it. We see patients with restrictive airway disease. So who are my patients, if we were due to PFTs, who typically have restrictive airway disease? So if I have a really obese patient, this might not be for them. If they've got some spinal issues or fibrosis or things like that, sarcoidosis, right? That's going to be more of a restrictive airway disease, okay? So we have to look at all those things before giving Sodalol, okay? Corvert is done only by IV, and we can give it instead of giving the actual cardio version. That's why it's called Corvert. It's actually an IV cardio version, okay? So if we had AFib, aflutter, and we want to do it really quick, we can give this med, and hopefully it will convert them back to normal sinus rhythm. I cannot give a class 1 or any other class 3 med within 4 hours of giving this, okay? And you're going to have to make sure that the patient's been on anticoagulated Coumadin, heparin, something before we give this, okay? All right, class 4 are our calcium channel blockers, okay? So verapamil and ditilazim or cardizem, okay? Again, calcium channel blockers. What's it going to block? My calcium channels, okay? We're going to use this for SVT, and we're going to use it for ventricular rate control. I'm going to block those calcium channels in the AV node and slow it down. So if I can't take a beta blocker, here's the deal. I got a really bad COPD patient. I got a really bad asthma patient. I can give them a calcium channel blocker instead of a beta blocker, okay? Now, I love beta blockers for heart failure, chronic heart failure, but if they don't have chronic heart failure and they've got COPD, let's put them on a calcium channel blocker. We also see this when, so we talked about the tolerance, right? And when we just keep giving these meds to the beta receptors, they can get tolerant. So maybe that beta blocker is not working anymore. Now I may have to switch them to a calcium channel blocker, okay? Oops, sorry about that. Okay, some miscellaneous drugs that don't, that do some things, and we already talked about digoxin, right? It's an AV blocking or has vagatonic properties. It's going to prolong that that refractory period. It's not a first line drug, and we like beta blockers more for heart issues. Okay, adenosine. Okay, so here's one we have to watch out for is adenosine. Okay, so if I've got a patient in SVT, this drug has a very short half-life, about 12 seconds. And this is a scary drug, and it's a drug that's in short supply actually right now. So what will happen is I've got a patient in sustained SVT, and I want to get rid of it and get them back into normal rhythm. So they'll pull up adenosine. And what you're going to do is someone's going to hold up the arm, okay, and we're going to push it through there, and then you're going to flush. And what you're going to see on the screen is it basically is a hard reboot of your heart. You're going to see basically a flat line, and everybody's holding their breath. That now the SA node takes over, and we get a normal sinus rhythm. It can cause bronchospasm. It can cause dyspnea, hyperpnea, cough, but guess what? What else it can cause is a flat line. And it does, because it's basically a hard reboot of your heart. okay? And everybody's on pins and needles, and you have your paddles ready and your epinephrine in case they do not come back, okay? Okay, so let's talk about sudden cardiac death. Okay, so we're going to talk about some, y'all took ACLS, so this really should be nothing but review for you guys. So sudden cardiac death, leading cause of death in the United States when it comes to accidents like that. We have your guy out there running for the first time in months, or he's just starting an exercise program, and they just fall over, right? They went into VFib, okay, or pulseless VTAC, or PEA, or asystole, okay? So if we get that sudden cardiac death, what is our goal? Our goal is to get them to sinus. First, our goal, if they're in PEA or asystole, is get them into a sinus rhythm, get them into a rhythm. But if I'm in VTAC, VFib, I want to get them to a sinus rhythm. I want to then prevent any further sudden cardiac death. I'm trying to prevent neurological damage. So someone tell me how we prevent neurological damage, right? So if I have that patient who came in, what is one of the things that we'll do? We'll put them on the Arctic sun, right? So the Arctic sun will cool them down, slow down the metabolic rate, okay? Thereby slowing everything down. We're not losing as much, hopefully, neurologic damage. So how are we going to restore this rhythm? CPR and minimize the time to getting defibrillated. We all know that CPR and how fast we get them to an AED or an actual defibrillator is going to save their brain and maybe save their life. Okay, so epinephrine's the first drug. All of y'all have been in codes, and epinephrine's the first thing. And yes, you need to know the dose. It's a 1 milligram dose. Okay, so we're going to push that epi. It's going to stimulate the alpha-1 receptor, so basically coronary and cerebral, so your brain and your heart arteries, everything's going to constrict, okay? And then it has some beta-adrenergic activity. So when I hit those beta-1 receptors, it's going to try to increase the heart rate, okay? And so we're trying to get your heart going, trying to get the blood going, come on. If I've got a metabolic acidosis, epinephrine doesn't work as well. So now we have to figure out metabolically what's happening and fix the metabolic problem. Because remember, when anybody codes, remember your H's and T's? Oh, I just heard everybody groan. H's and T's. You have to fix the H or the T, or we don't bring them back, right? Ultimately, we can do some things, but you've got to fix the H's and T's. But epinephrine is going to be our first line drug. Okay, and then vasopressin will be another one. Okay, I'm going to hold on to water. It's going to very potent vasoconstrictor. We're going to give it one time. So maybe we've given a couple of epis and we decide the epi's not working. So you'll hear them say, let's give a dose of vasopressin. We do it once during a code, only once. Okay, and then after that, we have to go back to epinephrine. All right. So basically we're saying, epinephrine's just not getting it done. Let's try something different and see if this person's body likes the vasopressin. So maybe we've given 2 epis and we go, oh, okay, vasopressin. All right. And then atropine, a 1 milligram IV push, asystole or PEA. So we're going to basically go with epinephrine, and then we're going to give atropine, epinephrine, atropine, atropine, right? It's going to block acetylcholine, okay? And I really don't care that it's going to make us, because atropine's an anticholinergic drug. I don't care if it gives me dry mouth or urinary retention or constipation because you're dead. I don't think we care about that. So if I'm in asystole or PEA, you're going to see us give atropine until we can get something back, because there's nothing else I can do. I can't defibrillate this patient because there's no electrical activity to defibrillate. Please do not tell me that you are going to shock someone who is in asystole or PEA, okay? Okay. All right, sodium bicarb. So what is the thought behind giving sodium? We don't give it a whole lot. We do give it, okay, but it's not going to be the first avenue that we go. So what is happening when this person's down? They're getting usually acidotic. So we usually will start with the epinephrine, maybe the atropine, epinephrine, atropine, or a vasopressin, and then we'll say, okay, go ahead and give a bicarb, because the longer they're down, the more acidotic they're getting. So a lot of hospitals do a gas during the code, and they just do it with an iStat. So it's very much right there. It's a point of care testing, and they can see, yep, they're very acidotic. Let's give a sodium bicarb. We just assume that they're acidotic, okay? And we basically, sodium is 1 milliequivalent per kilo, okay? We're trying to keep this pH at least 7.2 or above. And when we give sodium bicarb, that's why it's important for you guys to ventilate well, because it will increase CO2 levels, okay? So that's where we need to make sure that we're ventilating this patient, and we have them maybe on an end tidal to make sure where our CO2 levels are at. Magnesium. If I haven't drilled this one into your head yet, I don't know what else to do. If we see VTAC and it looks like torsades, you're going to give magnesium. If we say, hey, what was this patient's electrolytes? And they say, oh man, they had a critical or a low magnesium, we're going to give them some magnesium, okay? 1 to 2 grams, all right? We're going to give them the first one, and then we may give them one more after that, okay? We do have to be careful with those kidney patients, because it can cause toxicity, okay? Well, if they're dying, I don't think they're going to care about that, and we can take care of that once we have brought them back, okay? Okay, so let's talk about some alternate routes. So we all know we're supposed to try to get 2 nice big large bore 18 gauge needles in these arms to give this. But what if I don't have an IV to give it? So one of the routes we can do is that intraosseous, right? So if we go down your knee to that tibial ridge just below, I can put it right in there. And basically it's, it looks like a big spike that you stick in the bone marrow, okay? We use this a lot for kids because kids, when they go into cardiac arrest, they have such small veins anyway, they just collapse. This is the easiest way to get them meds, especially infants. But adults as well, when they've gone down, we've got no circulation. It can be very difficult to get an IV. So you'll see that interosseous done. We can do it right there at the tibial. I've seen it in the shoulder as well, okay? Once they get in and we bring them back, then we'll get an IV. So basically, you don't really want this intraosseous in 3 to 4 hours. I know they'll actually spread that out to about 12 hours. Just enough time for the doc to get that central line in, for somebody else to get a large bore in, if we can get that. But what if we can't get any of that in? Then guess what? If we got an ET tube in, we can give meds that way. And what meds can we give? Naloxone, atropine, vasopressin, epinephrine, lidocaine. Now, we don't give lidocaine anymore. We give amiodarone. So just make that L to an A and give amiodarone. When we give these doses, so if I were to give epinephrine down the ET tube, the normal dose is 1 milligram, right? You're going to give 2. You're going to double the dose, and then you're going to flush with a 10 cc syringe down and bag in, okay? All right? That's what you're going to do. You're going to flush it down the ET tube, put your med down there, and then flush with 10 cc's, and then 5 to 10 nice rapid ventilations. You're trying to push that med into the lung. So this is the one time you are going to bag faster than that, 12 times a minute. All right. So just make sure you know that. Okay. That is everything for chapter 21. I hope you all have a great Monday. I hope the test went well. And I will see you guys on Tuesday.